The message is that simple protocols do not work in critical care medicine. You need to have the big picture. And, arterial pressure, what should be the optimal blood pressure level in septic shock? Should be individualized. How can you have the answer from a study where you randomize patients for a higher or lower blood pressure? It doesn't make sense. Of course there is no difference in outcome. And hopefully so. Otherwise, we would not have to think at the bedside. We would just go for a given arterial pressure and then go for a cup of coffee. Central venous pressure, of course it doesn't tell you much about the amount of fluids you should give. Cardiac output, what do you do with the cardiac output value? If you are simplistic, you say when it's high, it's good. When it's low, it's not good. SVO2, same thing, bang, early goal-directed therapy doesn't work. And if you don't believe the single studies, you just put them together, you make a meta-analysis. 3 negative studies result in a negative meta-analysis. What else? Well, we need to go back, prudently, but we need to go back. And hopefully we are all going into an era of personalized medicine. That's my editorial on the 3 P's, P letters in intensive care medicine. We too often go down to poorly defined populations when we should try to go up, perhaps not to precision medicine, let's leave it to the oncologist, but at least personalized medicine. So yes, the blood pressure must be individualized, starting from a careful clinical evaluation. Yes, cardiac output should be, well, first, the central venous pressure, we need to evaluate it in a dynamic way using a fluid challenge technique as recommended by the Surviving Sepsis campaign. Now, for the cardiac output measurement, we need to, as I said in another session half an hour ago, we need to consider cardiac output as just the amount of blood being pumped by the heart in 1 minute. It's a little bit analogous to the speed that you can reach on your car. It needs to be adapted. You go faster on the highway than in the center of Vienna, of course. So the same thing is true for acutely ill patients. Why do you want to have a single value of cardiac output for every single patient in your department? And that's how the interface between cardiac output and SVO2 is very important. SVO2 gives us some information about the amount of oxygen which is left at the venous side of the vasculature. You may say that's a global variable. Yeah, but cardiac output too. You don't know how much of the cardiac output goes to the kidney, to the muscles, to the brain, etc. But we know that normally SVO2 is about 75% in you and I, maybe around 70% in the critically ill patient who has a lower hemoglobin level than you and I. So that's important because if we consider oxygen delivery, of course, very important, cardiac output, hemoglobin, oxygen saturation, we would like also to know how much oxygen is left at the venous side of the vasculature. So, what is early goal-directed therapy? People could say early use of antibiotics. No, that's not true. It could be early use of dobutamine, not necessarily so. People misunderstood sometimes what Rivers meant by early goal-directed therapy because it's really what Rivers meant. So perhaps to some extent it's good medicine. Early resuscitation, early complete resuscitation in the critically ill patient with sepsis. And as we know, the rationale is that in sepsis, normally the cardiac output is relatively high and SVO2 is relatively high. Not that the extraction capabilities are maximized, not necessarily so, but there is this peripheral disorder that leads the body to actually leave more oxygen at the venous side of the vasculature. So typically, it should be a relatively high cardiac output, a relatively high SVO2. And indeed, Rivers had the good idea to insert a central venous catheter instead of a Swan-Ganz catheter to simplify the assessment. We don't need the Swan-Ganz to have access to the mixed venous blood, but we would look only at the saturation in the superior vena cava. And if we want to increase oxygen delivery when SvO2 is not normal or high, well, basically we have three things we could do. Give more fluids, give transfusions, and give the butamine, right? Once we have corrected hypoxemia, the patients are already tachycardic, and they may be somewhat hypotensive, or at least there is no room for vasodilating therapy. So by doing so, Rivers did not use more mechanical ventilation or vasopressors, but indeed showed a difference in the use of fluids during the first 6 hours. Transfusions, transfusions, and the butamine. And actually, if the use of fluids did not result in significant differences after 72 hours, there were still more patients being transfused in the early goal-directed therapy group. So if the subsequent studies are negative, is it that the physiology is wrong or that the trials are wrong? And I have no problem in saying that these large prospective randomized controlled trials looking at very heterogeneous populations are a waste of time. The next example is the comparison of two crystalloid solutions. People don't know what is in the solutions if they just want to find out whether saline is better than plasmalite or plasmalite better than saline. They have a different composition. We need to individualize this. So I think, and that's what we wrote in an editorial with Daniel De Backer, that there are some differences in these trials. Of course, the patients in the Rivers study were sicker than in the subsequent studies, but also they were more likely to be transfused. Wait a minute, we have a Scandinavian study showing that we do not need to transfuse more than what we do. That's correct. That's exactly what that study showed. It was a study on over-transfusion. In one half of the patients, 2/3 were transfused. That's already quite a lot. In the other arm, 100% of patients were transfused. We don't want to transfuse all our patients with sepsis. So again, you know, large study, you put a lot of patients in it, and then you end up with negative trials. You end up with a publication in the New England Journal of Medicine, okay, but it does not help us, does not help. So I think these are good news, actually, because it indicates that we still need doctors to think a little bit at the bedside and to understand that the low SvO2 can be due to many things. I spoke about it at another session. There may be people with a low SvO2 in the room. But certainly in Vienna, there are people walking with a low SvO2. Now we speak about sepsis, septic shock. Okay. Forget about early goal-directed therapy. Measure SvO2 or SCVO2. It's not that simple. Exactly, it is not that simple. Because if the SCVO2 is below 70%, but if the patient is stabilized, you don't need to do something about it. You don't need to over-transfuse, I agree. And if the SCVO2 is at 70% or above, but if your patient is still poorly perfused, still oliguric, yes, you may still have to do something about it. So SCVO2 should be taken into a general context and not as an individual variable. Correct hypoxemia first, then look at cardiac output. If it's high, look at hemoglobin levels. If it's low or inadequate, look at whether you need to give more fluids or some dobutamine, a little bit of dobutamine. In septic shock, yes, even in patients who have no past history of heart failure, of course, there may be a place for it. So we need to integrate these variables and not just aim for an SCVO2 above 70% in all patients with septic shock. That does not make sense. Likewise, did you understand this study? They gave levosimendan to all patients with sepsis. All. Of course it's harmful. Of course. Results in more organ dysfunction. You don't need to give an inotropic agent to all your patients. And if you need to give an inotropic agent, measure, interpret, apply. Don't do it bluntly following a given protocol. So I didn't check the time, but I will not speak about, I'm okay? Okay. I will not speak much about lactate levels because it's not my topic. I'd like just to emphasize that lactate is not a sepsis marker. It's a marker of altered tissue perfusion. It's a marker of shock. So, of course, if the patient comes in with sepsis, we need to check the lactate levels, and not just once. We need to repeat it over time to make sure that it goes down. Some people call it clearance. No, it's not clearance. No. Repeated lactate levels reflect production and clearance. And, you can measure it only out once an hour, as we proposed 35 years ago. It was one of my first publications. And in the best conditions, it will go down by 10% in 1 hour, not more. So there is no need to measure it more often than once an hour. And again, it reflects production and elimination, and not just clearance. So SCVO2, lactate, some people have tried to compare the two. I think, no, we need to integrate the two, but not see whether one is better than the other. To me, repeating lactate levels is just like the compass in the boats in the past, making sure that we are in the right direction. So we check the lactate every hour to see whether we are in the right direction. And again, this implies the integration of data. Of course, you can put lactate and SVO2 together and you will have a better prognostic indicator. But so what? It's not prognosis that matters. I would like to know if my patient is improving with treatment. And sometimes I think that the patient is improving clinically, but lactate do not go down. So I'm worried. Or sometimes I am at the bedside with you and we wonder, are you sure this patient is improving? If you see the lactate levels go down and not go up, that's reassuring. So SVO2 will change more quickly than lactate levels. SVO2, it's right away. You start some dobutamine, you see the cardiac output going up, and if so, the SVO2 will go up. Lactate levels will be checked more intermittently. So I think that the RIVER study was actually of interest. It helped us, indeed, we all agree on that, to better resuscitate our patients early on. But I'm concerned about the fact that the results of early goal-directed therapy may be misinterpreted. I sometimes meet, hopefully seldom, but sometimes I meet with people who say, SVO2, no, I don't need to measure it. The studies on early goal-directed therapy are negative. No, time is essential. We need to treat these patients rapidly and efficiently, but there are no single recipe. Exactly as for fluid administration. Don't try to simplify. With a simple protocol, it won't work. We need to take into account a number of elements. So SCVO2 should not be considered in isolation. It's an additional variable in complex cases. Actually, you know what? We may not need SCVO2 early on, in the early resuscitation. That's how our thinking may progress. I don't want to know the SCVO2 right away in the early resuscitation. But if the patient is still in shock after 1 hour, 2 hours, we don't know very much what to do, it could complete the picture and hopefully help us to better manage the patient. So SVO2 is the balance between delivery and consumption. Consumption, the lactate, the balance between consumption and demand. Both are important, and both should be considered together with other variables to make a meaningful interpretation of the underlying disorders and find the best form of therapy. Thank you.